Good evening, everyone. Thank you so much for being here. My name is Amy Lerman, and my role is community outreach on behalf of the parish school. We are eager to begin the Q&A with our special guest, Dr. Katic, and we are so honored to have you join us this evening. We do have a couple housekeeping items before we get started. You may notice that you've been muted upon entering the Q&A. And this is to ensure that everyone can hear the question and Dr. Katic's answers. For those of you attending tonight, please know that we're recording this meeting and the video will be used and shared later with everyone who registered for the event. Additionally, we'll be using the voice recording for an upcoming episode of our Unbabbled podcast. For those of you who are unfamiliar with Unbabbled, we interview guests from parents to industry professionals with the goal of providing guidance, insight, and hope to those touched by children who learn differently. Each episode covers topics related to education or child development. You can find us on your podcast player of choice or visit parishschool.org/podcast for more information. Please feel free once we get started, please feel free to wave us down and we'll go ahead and ask you to unmute yourself to directly ask your question to Dr. Katic. Of course, another option is to type your question into the chat, and that way it can be read by either myself, Meredith Krimmel, or Stephanie Landis. One last pro tip for everyone. If you want to go ahead, change your view to speaker, or you can even pin Dr. Katic's video, and you will be able to focus in on our speaker. Okay, without further ado, I am so pleased to introduce Dr. Katic. Dr. Katic has an extensive background in psychopharmacology, autism, major depressive disorder, schizophrenia, migraines in children and adolescents, adolescent and adult attention deficit hyperactivity disorder, and bipolar 1 depression. He served as medical director for numerous hospitals and treatment facilities, including Houston Clinical Trials, where he currently serves as president and medical director. Dr. Katic and his research have been successfully published in reputable scientific journals and presented at scientific meetings. Thank you, Dr. Katic, for being here this evening, and I'll let you take it away.
Super. Well, thank you. Thank you very much for inviting me. It's a little unusual to do this. In the past, I've always been able to see my audience. What I thought I would do, because I do tend to like to have these be free-flowing, open-ended conversations. This medium may be a bit challenging, but what I'm going to do is start off just with a sort of a quick little primer, in essence, of child psychopharmacology, some of the main conditions that we treat, the medications that we use, and then really after that, would like to open it up to questions and try and, again, answer as many questions as I can. So I think a good place to start is with ADHD. And the reason I would start with ADHD is because it is the most common psychiatric disorder that we see in children. Most studies tend to show about a 10% prevalence in the population as a whole. Some are a little higher, some are a little lower, but 10% in general of children have ADHD or meet criteria for an ADHD diagnosis. And that also actually progresses into adulthood, though about 50% of folks grow out of their ADHD. And so by the time you get to adulthood, the prevalence rates tend to drop into the 4 to 5% range. But ADHD, again, is the most common psychiatric disorder in children. Diving into the medications that are used to treat ADHD, there are basically two main categories. What I consider, and I think most professionals would consider the gold standard, are the stimulant medications. And they're the gold standard because they are, frankly, the most effective medications. They're actually some of the most effective medications in medicine as a whole. They're very, very effective. There are, second category would be the non-stimulant medications. I'll actually start with those first because there's fewer of them. The non-stimulants that are currently approved by the FDA are three medications. One is a drug called Strattera, and the other two are similar to each other in that they're old high blood pressure medications. One called Intuniv, or the generic is guanfacine, and the other clonidine, or sorry, Capvey, and the generic being clonidine. The reason the stimulants are the gold standard is, frankly, the non-stimulants are less effective than the stimulants as a whole. They do have a different side effect profile than the stimulants. So sometimes for some patients that can be preferred. But besides being less effective, they also take time to work. So these are medications that you have to take for at least several weeks before they really begin to kick in. And with Strattera, taking sometimes upwards of 3 to 6 weeks to reach full effect. So if your child or yourself is going to be taking a non-stimulant, you definitely got to give it a chance and don't expect an immediate response or improvement in your symptoms. Now moving to the stimulant category, there are, I believe at this point, 30 different formulations of stimulants that have been approved. But basically what you're looking at within the stimulant category are two main categories, one being Ritalin-based medications and the other being amphetamine-based medications. And so some of the Ritalin-based medications that you might have heard of are things like Concerta, Focalin. There's some of the newer ones, Adhansia. There's actually the first ever approved stimulant given at nighttime, a drug by the name of Jornay PM that is dosed at 8 or 9 o'clock in the evening, but does not begin to release medication until about 10 hours later, so about 6 a.m. the next morning. And all of these, and then on the amphetamine side, you have Adderall, which people are very familiar with, at least the name, and then Vyvanse. There are a few other, those are the two long-acting amphetamine-based medications. There are some short-acting ones that you may have heard of, like Aviccio. But again, those are your two major categories. Studies have shown, and it's frankly been my clinical experience, that all stimulants are equally effective. The amphetamines are not better than Ritalin. There isn't a particular drug that is better for inattentive ADHD or hyperactive. They are all equally effective. They all do also share the same side effects, the most common ones being decreased appetite and insomnia. The insomnia tends to improve, but unfortunately in children, decreased appetite tends to be a persistent and problematic side effect. All stimulants basically last 3 to 4 hours, and thus they are packaged into these long-acting forms, such as Vyvanse, a long-acting version of dextroamphetamine, to try and create a single-dose medication that can last anywhere from 8 hours, being the shortest of the long-actings. That would be Ritalin LA. Vyvanse, the dextroamphetamine-based medication I mentioned, can last 12 to 13 hours. Some of the newer ones claim to last even longer than that. There's a drug, Midaeus, which is a long-acting version of Adderall XR that may last up to 14, maybe even up to 16 hours. But really trying to, again, create a single-dose medication so that children aren't having to line up at the nurse's office, or for adults that they're not in the middle of a meeting and their short acting is worn off and now they're without medication. So again, ease of administration and maintaining efficacy throughout the day. So that's the ADHD category. There are some off-label medications that physicians will use that can include an antidepressant, Wellbutrin. There are also some pro-wakefulness drugs that you may have heard of, like Provigil or Nuvigil, that have some data indicating, again, some efficacy in ADHD, but again, less effective than the stimulants. I will throw out one other category in terms of some of the natural treatments, if you want to call them that, for ADHD. And there is data showing that omega-3 fatty acids have some effect in improving ADHD symptoms. Unfortunately, the problem really becomes as you're moving down from stimulants to non-stimulants, you're losing efficacy. And as you move down to omega-3 fatty acids, you're really getting down to not very powerful effects at all. So that's ADHD treatment in a nutshell. Then I thought what I'd like to do is move on to another large category that we see in children and most definitely in adults, depression and anxiety. And the reason I'm going to clump those two together is because the treatments are very similar. In focusing on children, because I'm a child and adolescent psychiatrist, there are currently 2 approved medications for the treatment of depression in kids, and that is Prozac and Lexapro. Those 2 belong to a class of drugs known as SSRIs, or selective serotonin reuptake inhibitors. That is believed to be one of their primary mechanisms of action. In childhood anxiety disorders, there are 3 drugs that are approved by the FDA, and that's specifically for OCD. And those 3 drugs are Prozac again, Zoloft, and Luvox. Again, all 3 being SSRIs, so sharing the same basic mechanism of action in inhibiting the reuptake of serotonin in the central nervous system. Now, when you look at adult depression and adult anxiety disorders, there's a much larger group of these SSRI medications. So for instance, things like Paxil that you may have heard of, newer ones like Trintellix and Vibrid. So again, but mostly all of those have, again, this common mechanism of action. One group of medications with a slightly different mechanism, which are known as SNRIs, serotonin norepinephrine reuptake inhibitors, again approved for either the treatment of depression or various anxiety disorders. And those drugs would include medications such as Cymbalta, Effexor, Pristiq. Now, none of those have ever been approved in children. Some of them have done studies. I was involved in a number of those studies. So for instance, using Cymbalta as an example, Cymbalta was unfortunately not able to separate from placebo in an adolescent depression trial. But what was interesting about that trial was that there was a comparator drug. So basically you had Cymbalta, Prozac, and placebo. And Prozac, which I mentioned previously as having been FDA approved, actually failed to separate from placebo in the Cymbalta Prozac placebo study. So it can be difficult to demonstrate efficacy for these medications in children, and people argue and scratch their heads over why that is, and there's all sorts of theories. But again, so there's a very limited number of medications that are approved by the FDA. It doesn't mean that physicians don't use other off-label medications in children, and that's not unreasonable, particularly if one has exhausted the currently approved therapies. So that's depression and anxiety disorders, again, in a nutshell. And then the last major group, so I'm not going to focus on psychotic disorders or schizophrenia this evening, but more looking at, again, conditions that one might encounter in children. So the last major sort of grouping, and it's not so much that these disorders have similarities to each other, but the similarity being the medications that are used to treat them. And that would be bipolar disorder and then autism spectrum or autism disorders. And basically the common medications that are used to treat those 2 conditions are what are commonly referred to as atypical antipsychotics, or sometimes known as mood stabilizing medications. And so in bipolar disorder in children, excuse me, there's a number of different medications such as Zyprexa, Risperidone, Seroquel, Abilify, and others that have been approved. And several of those medications, again, such as Risperidone, Zyprexa, and Abilify, have been approved for the treatment of symptoms associated with autism. All of those medications, again, share a similar mechanism of action, namely blocking dopamine receptors in the central nervous system. So that is their commonly shared mechanism of action. And, with that, I thought I'd go ahead and start to take some questions and try and drill down to more specifics as people ask questions.
Thank you so much, Dr. Katic. Yes, we do have one question that was sent in ahead of time. Thank you very much. And the question is, are stimulants a safe way to treat 6-year-olds for ADHD? What if their behavior becomes outrageous? Do you quit taking the stimulant, or do their bodies need time to adjust to the medication?
So is that the question? Yeah, so stimulants are a reasonable approach in treating 6-year-olds, and most, well, actually all of the stimulants are approved 6 and above. And so there is data from studies indicating efficacy in children that young. And just so you know, the FDA actually has requested, and a number of studies are being done by various pharma companies in children 4 and 5 years of age. And that data will be coming out over the next few years. So stimulants, again, are approved. As I mentioned earlier, they are the gold standard. In terms of altering a child's behavior in a negative manner, that can occur. You can see children become more moody, irritable, weepy, and that can occur sometimes on the medication. And by on the medication, I mean the duration of the drug. So let's just say a child is on an 8-hour long-acting stimulant. You could see it potentially during those 8 hours. More commonly, what one tends to see is that kind of moodiness or irritability will occur as the medication is wearing off, sometimes known as a rebound, where the child actually is, again, more moody, irritable, possibly more hyper, and that typically wanes after 30, 60, maybe 90 minutes. Is it reasonable to hang in there? It is, because clinically what one sees and what studies show is you'll tend to get the most side effects in the first week, and they will tend to peak, and they do tend to abate over time. Except for the one that I mentioned at the start, appetite suppression. Unfortunately, appetite suppression tends to simply be a persistent side effect in children. I can't remember all the details of the question, but one of the things I'll say also, one of the nice things about stimulants is that they do give you quick answers. And so literally you will be able to tell within a day or two, depending on the dose that's chosen, to maybe a week, as one is possibly increasing the dose, if it is an effective medication. But the other nice thing about it is if it's not effective or is causing problematic side effects, if you don't give a stimulant the next day, it's gone. So you can literally be in and out of a trial of a medication within a day, 2 or 3. And so unlike some other medications where, if you've taken it for a week and you stop it, it's going to take a week or so to get out of your system. That is simply not true with stimulants. That's one of their advantages possibly, but it's also one of their disadvantages, because if you don't take it the next day, it doesn't work, obviously. So sometimes I'll describe them to families as, giving us a quick answer, yay or nay. And if it's yay, we hang on to it. If it's nay, you can stop it and move on. And one of the things, I'll just go back to sort of my summary on ADHD that I do want to mention. I said that all of the stimulants are equally effective. They do all share the same side effects. It's not uncommon also for patients to try multiple stimulants. And so if your child did not do well on, say, Focalin, and had some problematic side effects, it's not unreasonable to try another stimulant, because though they share the same side effects, you may not get the same side effects. And you may find, and actually my experience is that many patients will choose their final stimulant based on not efficacy, not that that was better, worked better than this one, but on side effects. I was in a better mood on that one, or I slept better on this one, I had a better appetite. Those are often the factors that drive which medication a person ends up taking over the long term.
And that's a really helpful answer, because what you ended up doing was answering quite a bit of the second part of this person's question, which was, is there a way to know which medication will work best for your child besides trial and error? And you really just spoke to that a lot.
Yeah, unfortunately, it really is trial and error, and it's a matter of picking a starting point. As I said, again, there isn't one drug that's better for inattention or hyperactivity. Different doctors have different, frankly, practice habits, and they're all reasonable. I tend to start younger children on Ritalin-based medications. Ritalin is a slightly less potent stimulant than the amphetamines, and so I'm rationalizing that maybe they'll tolerate it better. But I do have many kids, young kids, on amphetamine-based medication. So it's really a matter of picking your starting point and starting and seeing how it goes. The good news is, again, barring side effects, these are very effective medications, and many kids will respond well to whichever medication they're placed on first, and rapidly so.
Wonderful. Next question, would you ever prescribe a mood stabilizer with a stimulant or non-stimulant?
So yeah, what you're touching on there is what sometimes is referred to as a polypharmacy, and polypharmacy really occurs generally because these conditions run together, so they are comorbid. So for instance, using ADHD commonly runs with anxiety disorders. It can commonly run with depression. It can commonly run with bipolar disorder. And so it's not uncommon to have to use two different medications to, in essence, treat two different conditions. So a stimulant or a non-stimulant for the ADHD, and then a mood stabilizing medication possibly for bipolar disorder, or for a child who's on the autism spectrum, to manage some other mood symptoms or behavioral issues that the stimulant simply can't address, because its main target, frankly, is ADHD symptomatology.
Okay.
I have a question. Oh, are you done? Are you still have a question?
Mm-hmm. Yeah.
I'm on here because my son, I don't know if you're familiar with disruptive mood dysregulation disorder. My son, he was diagnosed with ADHD at the age of 6, and he was on numerous stimulants, and they all made him even more aggressive. And so the doctor, we just stopped. But later on at 8, he was diagnosed with the ODD, mild depression, mild anxiety, put on Prozac. It made him more aggressive. He was hospitalized, put on Risperidone. Risperidone made him aggressive more, made him gain 20 pounds. Moving on to 9 years old, then he was diagnosed with the DMDD, put on more Depakote. I mean, he's been on over 25 plus meds, and they're not working with him except making him just gain weight. I mean, he was stable for maybe 5 months on lamotrigine and Geodon, but that's really it. But basically in 2 years, he's been hospitalized 4 times. He was 60 pounds, now he's 135 pounds. I mean, he's been working with a neurologist. He had an EEG done. He had some abnormal spikes, frontal lobe deficit. And I don't know if you're familiar with Dr. Matthews' protocol with the trileptal and the adamantine. I can't pronounce it right, but I mean, he's just been on a slew of medicines, and really, they're just not really working. Currently, he was on Latuda with his last hospitalization, which was in September. But my insurance, I mean, it's over $1,000, so I just couldn't afford it. But now he's on Zyprexa. He's only been on it for 2 weeks, and he's eating everything in the house. He's a little, he's in a behavior program at school, so um he a little slightly hasn't been hitting this week, but he's just eating everything, and I'm just concerned about, I don't know, even the doctor, we don't know where to go from here with these meds because he's been on so many. Of course, he has poor impulse control, but he hasn't been on stimulants in a long time. And so I'm just kind of at a loss with these meds. And then we even had the genome test done to show which meds may go or not. And mostly all the antipsychotics are in the caution area. So it's just been a long battle with these medications.
Yeah, I mean, I'm sorry to hear that, and unfortunately, I mean, what you're touching on is that you know, those kinds of issues do come up for some children, unfortunately.
Mm-hmm.
And you know, one of the things that that I would say to you is, I've seen children like you describe your son,
Mm-hmm.
and many times they will get better over time. I realize that won't help you right now today, but you may find that, you know, when he's 14, 15, that things settle down. But the other thing that I would say is, you know, I keyed in on, and again, I don't want to give treatment recommendations. I don't know your son, but I keyed in on, you said that at one point on Lamictal and Geodon, he did well. It may be worth going back and re-exploring medications. I've seen many times where patients respond to something, maybe lose their response, and you go back to it again at some later date, and it well again. And the other thing that I would just say, you know, you mentioned at the end that he hadn't been on stimulants in a long time. It may be worth reconsidering that. I've seen many times where young children, you know, 5, 6 years of age, don't tolerate the stimulants as well. I think you said it made more aggressive. Same kiddo, given the same medication, 3, 4 years later, they respond much better. And I think sort of, you know, your brain is developing, things are kind of coming online, if you want to think that way. And again, a child may do well on a medication at a later date that they did not do well on. And as I said earlier, one of the nice things about stimulants, they give you quick answers. You will know pretty quickly, you know, is this a good move or not? You know, excuse me.
Yes.
Yeah,
You can
no,
know pretty
unfortunately,
quickly, because I was a special ed teacher, and I can know if a child came to school one day, he was calm, and then next week if he didn't take it, you know immediately, like you said, if he didn't take his medicine.
right.
So, but that's interesting what you said. Maybe I will try, because he will be 11 in January, and maybe we can try a stimulant. I didn't ever think about that maybe we can try the same one again. That's interesting.
Yeah, it may be worth considering. And you know, unfortunately, again, the other thing you really touched on with the atypical antipsychotics, weight gain, unfortunately, is a real problem for a lot of, and the real challenge there is also not only that it occurs, but once it occurs, it's not easy to get off. And I'm not talking about the medication; I'm talking about the weight.
Yes, and of course, a lot of people say, "Well, just feed them a healthy diet." But when you have a kid who's volatile and you don't give them, you know, kind of what they want, you get punched in the face, literally. You know, so it's not that simple just to say, "Oh, let me feed them," you know, a healthy diet. But I may bring that up to the doctor, maybe trying a medicine, like you said, that didn't work in the past, maybe that. And so what age for boys for
And
puberty,
so,
is that a factor?
ma'am, guys, I'm so sorry to jump in and interrupt, but we've got quite a few questions, and I want to make sure that we get to everybody in the hour that we've got. Thank you so much.
They're probably around 14, 15. So in the next few years, hopefully.
Okay. Well, thank you so much for answering my question.
Okay, so another question that we've got here is, how often do you recommend taking your child off medication for a trial period. This to determine if they can achieve success off medication.
Yeah, it's a great question. I think let's break it down in terms of some of the diagnoses that I've gone over. So ADHD, as I said earlier, does get better as you get older, and 50% of children who meet criteria in childhood do not by the time they get to adulthood. It's not unreasonable, in my opinion, to do trials off of medications. For ADHD potentially. And what one is looking for is, as you come off of the medication, do the symptoms manifest themselves again, whether it be behaviorally, academically, a combination of the both. And if they do, well, then okay, it's not the time to stop the medications. One goes back on them. Now, it gets a little more tricky if you start to look at things like depression and anxiety. Anxiety disorders, unfortunately, do tend to be chronic. They do wax and they wane, but they don't generally go away. And so many patients, once they respond to, let's just use Prozac as an example, they may take it for many years. Again, not unreasonable as the child is aging to consider possibly coming off of the medication. What I tend to do with my patients is I let the child know that they're in the driver's seat because they have to be comfortable to come off the medication. And if they want to do so, then we gradually taper down over a period of several months possibly. And what we're looking at as we're coming down on the medication is, again, does the anxiety recur? If so, is it less severe? Can you treat it with therapy? Or is it, again, bad? Do we need to go back on medications? Again, not unreasonable. Depression, unfortunately, there just isn't really good systematic data in terms of what to do there. In adults, the recommendations for a first episode are to treat for at least a year. For recurrent episodes of depression, to treat for longer periods. In kids, we again just really don't have good data. So what I find myself doing is taking the adult paradigm and applying it to kids. And so again, I would generally recommend treating a child with depression for at least a year if one achieves a response on the medication. And then again, possibly coming off and seeing how it goes. But cautiously monitoring, and if symptoms recur, resuming medication. For conditions like bipolar disorder and again, the autism spectrum disorder, those symptoms tend to be more persistent, and unfortunately, you're looking at probably more chronic and longer term treatment of medications. It's not unreasonable, possibly, as children are developing, if say some of their outbursts, as we were talking a minute ago, are subsiding, do they need as many medications or that high of a dose? But, again, I think it really needs to be done systematically with a plan of how to taper off the medications. With the stimulants, you just stop those, but with the others, systematically, gradually tapering and carefully observing for, any recurrence. And if so, having a plan, to resume medication or what to do next.
Thank you. Another parent was curious to know whether there are particular behaviors that Abilify is more effective at treating than Risperidone, and whether Abilify can be given in addition to Risperidone.
It can. That's not the preferred modality. It's really, one tries to stay away from combinations of atypical antipsychotics if possible. I mean, that being said, I do have a small subset of patients where that just seems to be what works best for them. Your concern with multiple agents of that sort is, frankly, that you're stacking the deck, in essence, from a side effect standpoint. But they can be used together. Now, is one, again, better than another for certain symptoms? No, that just, I think doctors at times have sort of ideas in their head about what may work a little better for this or that based on their own experience. But is there research data that clearly indicates that this drug is better for depressive symptoms or anxiety, no, there just simply isn't. And when you look at it, I mean, if you bother to read these studies that the FDA approves these drugs on, what they tend to show is that these drugs are effective across the spectrum of symptoms. Okay, so whatever the depression symptoms are for an antidepressant, whatever the ADHD symptoms are, again, so inattentive and hyperactive symptoms, these drugs work equally well across the spectrum of that disorder symptoms. Whoops, no, I can't hear you.
Excuse me, sorry about that. At what point or age do you determine when you should check for ADHD or anxiety disorders for a child that is on the spectrum?
Oh gosh, yeah, that's a tough one. I don't know that there's a particular age that one is looking at. It really it tends to either sort of manifest itself or it doesn't really, and it's unlikely that you're going to be looking at a lot of that prior to the age of, say, 4 or 5. As a child is progressing into school, ADHD symptoms, it's not that they become more prevalent or they become more problematic in essence, not that they're getting worse, but because of the demands that are being placed on the child. One can also see anxiety symptoms begin to develop in children as they get into either sort of pre-teen years or early adolescence. Though anxiety symptoms can also manifest themselves in young children, 4, 5, 6 years of age. So that's a hard question to answer in terms of when to look for, at what age to look for these symptoms emerging.
Okay, thank you. The next question says, would you recommend trying a different extended release stimulant if your child is on one but still needs booster doses throughout the day? Increasing the extended release morning dose caused irritability.
Yeah, so a couple of things that yes, I think it's reasonable to look at other extended release medications. There are some of the newer ones, for instance. I'm not sure if your child is on a Ritalin-based one, but Adhanzia, which is a new Ritalin-based stimulant that possibly can last up to 14 hours from a single dose, and may not require as extra or booster doses later in the day. But there is also a subset of children who simply seem to go through long-acting stimulants faster than one would expect, and where you are having to use booster doses. But it's absolutely reasonable to try and switch to other long-acting stimulants and see if you can get a better fit, because it can occur. And again, as I said earlier, these give you quick answers. You will literally know within a few days to a week or two if you've made the right decision.
How do stimulants typically affect someone with ADHD that also has high functioning autism and acute hearing sensitivity and high anxiety?
That's a good question. Well, let me take a first pass at it this way. When you look at one of the challenges in treating patients with autism is that they present with a number of other symptoms, ADHD type symptoms, anxiety symptoms, mood symptoms. But when you look at treatment with medications, and when you look at what studies have shown, their response to those treatments is often not as robust as one sees in the original condition. So let me give you an example. Trying to treat ADHD in a patient with autism, many studies, well, let me back up. If you look at ADHD treatment with stimulants, and most studies will show 80 to 90% efficacy, very powerful efficacy. In patients with autism, the response rates drop to 30 to 50%. Okay, so why is that? Well, in my opinion, it's because ADHD and autism is different than ADHD without autism. And so it gets more complicated. And then, you touched on the other sorts of issues in terms of hypersensitivity to sounds and anxiety. So, that's where you then end up looking at combination of medication treatments, but also need to realize that the responses that you're going to get from these treatments may not be as robust as one would like. Another example being in patients on the autism spectrum, they present with OCD-like symptoms. And I stress the like because those studies have shown that Prozac, which is approved in OCD, are effective. It's not going to be as effective, unfortunately, as in a patient who just has OCD without the autism spectrum. And not to try and dissuade you, or it's, again, reasonable to try, and you may see response. And sometimes you may see really robust response, but you also have to prepare yourself for, how much has this helped? What are the side effects? Is it worth holding on to this medication? Has it provided enough benefit to warrant its ongoing use?
Okay, we have one here that says, do you believe that genetic testing is an effective way to find the best starting point?
I'm smiling because I really wish it was. So here's my take on that.
Okay.
The mom earlier mentioned Genomind. There's a number of companies, GeneSight, and the problem with those is that the science has gotten ahead of the clinical studies, and so these gene tests, basically what they're looking at are what are called cytochrome P450 enzymes. So these are enzymes in your liver that metabolize medications, and we do know which drugs go through which enzyme systems. These gene tests show on these various enzymes, are you a normal metabolizer, a slow metabolizer, a fast metabolizer? And thus one can figure out how that might affect the blood level of a medication that goes through that pathway. They then also look at a number of the neurotransmitter transporter genes. And what is your profile on those various genes? Now here's the leap. They then try to make guesses as to what your profile on that neurotransmitter transporter gene might mean in terms of your response to a medication, and then combine it with the enzyme data and then create these algorithms that this might be a better medication, that might be a better medication. GeneSight did depression trials in adults, and they did show that if you picked the better drug, you had a 2 times higher response rate than if you picked the not so good drug. That was in one of their studies. In another study, they failed to show that that was true. So the problem here is we're trying to get towards personalized medicine, but we're not there yet. More studies need to be done to understand, how to use these tests and can they guide doctors. The way I tend to use them is in patients who've had strange side effects and problematic responses to medications, or who've been on multiple medications and seem to repeatedly fail and don't respond to those medications, in the hopes that, might this test be able to guide my choices, narrow my choices towards better ones. But, again, I think it's an interesting area. I hope it leads to better sort of decision trees for us, but it's still a little early to be able to say that we're there.
Very good. Okay. Here's another one. Do you ever recommend non-medical interventions before starting medication? If so, what do you frequently recommend?
So again, in ADHD, in all honesty, no, I don't typically. There are some, I think the FDA recently approved a computer game, basically, that one can use to treat ADHD. There is neurofeedback, and studies have shown, some efficacy in treating ADHD symptoms. But it's not something that I'm typically recommending as in lieu of medication, or most definitely not as a first line. If parents and patients want to go down those paths, I don't think it's unreasonable. Now, when it comes to anxiety disorders, there are many times where, depending on the severity of the symptoms, where I would recommend cognitive behavioral therapy. CBT has been shown to be equally effective to medications. And in the long run, I think is actually more effective, not in that they provide a better response, but what studies have shown and what you can see clinically is that meds and CBT are equally effective in treating anxiety. However, when you stop the medication, as I said earlier, anxiety disorders are chronic and many times the anxiety will come back. With CBT, patients, it takes them longer, frankly, for those symptoms to come back. So they sustain their response to CBT longer than they do to medications. And studies have actually shown that with CBT, you are literally causing changes in your brain that are similar to what medications do. So it's not just learning how to manage better. You are literally causing changes in how your brain is firing or functioning that correlates with what medications do. So again, that is a very powerful treatment and one that I definitely recommend, whether by itself, before medications, or even with medications.
Question, and that's a very helpful answer, I know, for many of us parents and educators. Do you recommend giving weekends or summers off medication?
So I think this question is specifically directed to ADHD medications, because the answer for the others would be no, because again, antidepressants, anti-anxiety medicines, mood stabilizers, they can take time to work. You want to maintain their efficacy. If you come off, symptoms recur, now you again got to wait weeks for it to potentially work. With stimulants, ADHD is always there. So treating it 7 days a week is absolutely reasonable. Like any other condition, ADHD is a spectrum. And by that, what I mean, there are patients who are more severely impaired and those who are less. And can patients come off of medications on the weekend, summers, and do well, even with their ADHD symptoms? Sure. On the milder end of the ADHD spectrum. And then when they go back on their medication, when school starts or they go back to work, the response again is immediate. So I don't think it's unreasonable with stimulant medications to come on and off. And really, I tend to let families make that decision.
Can I tag a question on to that though?
Mm-hmm. Yeah.
Have you ever heard personally from children who somehow internalize the change and notice, whether or not how it's affecting them, if they're able to recognize how it affects the people that they're with, whether or not they're getting reprimanded more, and whether or not that affects their self-esteem?
Yeah, so most definitely. I have patients of mine who they simply prefer to stay on their medication 7 days a week. They'll describe to me, I simply do better, and that can be from feeling calmer, less impulsive, and not only just impulsive in blurting out answers or running out into the street after a ball, but less impulsive in a mood fashion, that they're less irritable, that their fuse is longer. As well as also there's just that they're more efficient, better able at completing household chores, et cetera. And so I've most definitely had patients who've told me that. But other patients again don't like how they feel on the medications. They want to be off of it, or in terms of one of the parts of your question, no, they're not aware of how their symptoms affect others, and also aren't aware necessarily of how that feedback that they're getting may be negatively affecting them in terms of getting in trouble or getting, reprimanded. Yeah.
Right. So thank you very much. How do stimulant medications affect someone with ADHD and sensory processing disorder?
Well, that's a tough question in that there isn't a good blanket answer to it. In all honesty, there's a very good chance that that patient can do quite well on ADHD medications and that you won't get any sort of exacerbation of their sensory processing disorder. Is it possible that you could see some worsening of those symptoms, a heightened sensitivity? it is possible, but I would not allow it to dissuade me from trying a trial of a medication, and I'm thinking of a stimulant, if the ADHD symptoms are clearly causing, functional interference.
I have a question.
Yeah.
Do you find that anxiety and ADHD present similarly in young children?
That's a good question. It's a tough one. There's definitely an overlap for some patients, and so yes and no. ADHD, again, the core symptoms are inattention, hyperactivity, daydreaming, restlessness, etc. Now, anxiety, depending on the types of anxiety that you're talking about, can it interfere with your attention? Sure, it can. And so there can be that interplay. But the other thing that you also see, sometimes kids with ADHD can, again, have that short fuse, be irritable, right? Maybe a little explosive. But that can also be driven by anxiety, okay? And if you're sort of anxious or say you're obsessive and someone's interfering with your obsession, you might sort of, get a little angry, right? And so there's definitely an interplay that can occur there. I hope I answered your question.
You did. And like on top of that, at what point do you think if a parent suspects their child might have ADHD or anxiety, at what point do you usually recommend looking into assessment and treatment options?
Well, again, if it's interfering, then you most definitely should look into assessment, whether that be, psychological testing, educational assessment, right? Rule out learning disabilities, but also look at, or learning differences, but also look at, the possibility of ADHD symptoms. Typically, again, typically many times, this can be as young as 6-7 years of age. At other times, if the symptoms are more mild, you can see patients not present until they're later elementary or early middle school. It's the common entry points, just using ADHD as an example. You have the sort of pre-kindergarten; those are the really hyperactive kids who are sort of disruptive. Then the others who maybe make it until about third grade, and now again in third grade, the academic demands begin to increase a bit, and children start to sort of falter. Middle school, you have now 6-7 teachers. How are you going to stay organized, keep up with your work? High school, some make it all the way to college before they're diagnosed.
Yeah. We're going to take about 2 more questions and then we're going to wrap up. I know that we've got a couple in the chat that are private and a couple that are not, and hopefully we're going to try our best to move through everyone's, but we will be wrapping up as close to 8:30 as possible. So to respect Dr. Katic's time and the hour that everyone came to share together. Question, does reducing or eliminating food dyes or sugar have any clinically significant benefit in treating ADHD?
Yeah, unfortunately, that has not been my experience, that's necessarily the case, at least not in a large percentage of patients. If it is, it might be in a very small percentage of patients. It's nobody has asked the CBD question tonight, but I think it's sort of in that similar sort of vein. And what I'm saying by that is, if you think that might be an issue, or you think CBD could possibly work for some set of symptoms, do a study. And by that, what I mean is eliminate the dye and see if there's clearly a change. And if so, fantastic. You continue to eliminate it. If there isn't, okay, that's fine, move on. Likewise with CBD, you have your set of symptoms that you're trying to treat. There simply aren't enough studies out there to really warrant this, but look safe. Do a study. These are the symptoms I want to see improve. If they do, great, I'm going to continue it. If they don't, I'm going to stop it. So that's the way I tend to think about these things is, as long as it's not something harmful, do a study. This is what I want to see improve. If it does, fantastic. If it doesn't, scratch it off the list.
Here's a good one. For a parent who is on the fence about medicating their child or very hesitant to go that route, how do you explain to the parents the benefits of being medicated in order to ease their concerns, worries about side effects, or losing their child's personality?
How do I, that's a tough question. I think really what one has to be thinking about, naturally there's the concern about medications, there's a concern about side effects, long-term effects, though there really don't appear to be any negative long-term effects, particularly as you're thinking of stimulants, is the impact. So what I try and get parents to think about is the impact of the symptoms on their child's functioning. What you don't want to see, obviously, is that your child becomes down on themselves or demoralized. I'm stupid, I can't do it, I'm always the last one to finish. Or the other sort of behavioral issue, I'm always in trouble, I'm no good. And if you're seeing any of that sort of, those sort of complaints, then I think your level of concern should rise really more towards that. We really need to do something treatment wise, and I'm gonna just have to sort of take that leap and let go of some of my worries about possible side effects.
Okay, we've got two more. The first one is, do you recommend taking vitamin supplements with or without medication for ADHD?
I don't think they hurt. I can't say that I recommend them in terms of that there's some improvement in the response to medication or So I mean, I think that's a safe thing. I can't say that I think it helps or hurts.
Thank you. Okay, for a parent who has heard only negative information about ADHD medication, what would you recommend they read to get reliable information?
Oh, that's a great question. And there's actually, I'm not one to commonly recommend books, and it's either Tom Willens or Tim Spencer. I can't remember now which one of them wrote the book. They're out of Mass General Hospital. There's actually a primer on medications for your child, and it really goes through in much more detail than I did tonight. And let's see if you want to ask another question while I'm looking this up, I can tell you.
Oh, that's lovely. Okay, there was one last question, and this one is for a child that has both an ADHD plus expressive receptive language processing disorder. Do you feel that the non-stimulant drugs can actually cause more of a processing delay?
I can't say that, not necessarily. No, I can't say that I do necessarily.
Okay. Well, while you're pulling that up, I'd really like to take a moment to thank all of you who joined us this evening and put questions into the chat, because by your generous sharing, it really helped prompt other people to ask other questions. And I think that sometimes even when we don't ask a question, just by your asking it, it really does speak to so many of us who are signed on here tonight. So thank you to those of you that that showed up and asked questions, and thank you to those of you who attended and just listened so generously.
For some reason, I'm not finding it, but to that parent who asked that question, the author is either Tim Willens, Wilens, or Tom Spencer, and they're out of the Mass General Hospital, and actually wrote a really good book, as I said earlier, sort of medication treatment in children, and very detailed and thorough. And so it's a good resource if you want something to look up.
And Dr. Katic, if you were to come across it at a later time, we always send a follow-up with the recorded version, and we would be so glad to include that as well.
Yeah, for some reason, though Amazon knows everything about everybody, it's not coming up when I'm.
Wow. Well, this was an amazing hour. Thank you so much for lending yourself to the parish school community, the Caruth Center, our Unbabbled podcast. And we're so grateful that you were here. Thank you. Thank you so much.
Thank you for having everyone. Stay safe, stay healthy.
Absolutely. For those of you tuning in tonight, we hope that you will tune in again. We have upcoming free adult education webinars and Q&As scheduled almost every month. So please stay tuned for those. And good night.